Let's talk about cardio-renal syndrome. I like to think of two arms of cardio-renal syndrome. On the one hand, we have venous congestion, causing high central venous pressure, which transmits back to the renal veins, causing increased renal vein pressure. This eventually reduces glomerular filtration rate, causing a kind of congestive nephropathy. You also have the other arm, where you have reduced cardiac output, causing less blood flow to the kidneys, in conjunction with reduced blood flow to the rest of the body, like the skin, the liver, and the brain. In fact, there's been some studies that have shown that venous congestion is a more predictive marker of worsening renal function than reduced cardiac output. And various mechanisms have been proposed for the pathophysiology of congestive nephropathy, including congestion of the kidney veins, the capillary beds, and also altered hemodynamics at the level of the glomerulus. Management of acute kidney injury in the context of acute decompensated heart failure is typically directed by clinical clues. It's probably a good time to talk about the phenotype of acute decompensated heart failure. We can draw a table which categorizes phenotypes into warm or cold versus dry or wet, with warm suggesting adequate circulatory function and end organ perfusion, and cold the opposite, manifested by delayed capillary refill time, manifestations in the skin such as mottling and clammy extremities, as well as low blood pressure, which can sometimes manifest as a low pulse pressure. Other signs of hypoperfusion could be altered mental status and reduced urine output, and you may also see reduced urine output in venous congestion, as well as post-renal obstruction. When talking about wet or dry, wet typically refers to a state of volume overload, and signs of this will include increased weight from the patient's baseline, raised jugular venous pressure, generalized edema, including pulmonary edema, some ascites, some gut edema, which can sometimes manifest as nausea, as well as the typical lower limb edema. You may be able to auscultate the S3 heart sound, which is very specific for left ventricular volume overload, as well as some secondary mitral regurgitation. And on echocardiography, you'd see a dilated or non-collapsing inferior vena cava. Each subsection has its own treatment plan. For example, volume overload is treated with diuresis, and sometimes vasodilators such as nitroglycerin if needed. Circulatory failure is perhaps somewhat more insidious, however very important to pick up on, as these patients would need higher care such as the intensive care unit for installation of circulatory support. Let's look at some cases. A 67-year-old male presents to the emergency department with worsening shortness of breath over the last 3 days and swelling of the legs. He has had to use 2 pillows instead of his usual one, and he has found himself waking up at night short of breath. His blood pressure is 140/90, and he has a pulse of 90 beats per minute. His oxygen saturation is 93%, and his temperature is 36.7. On examination, you can hear some crackles at both sides when you listen to his back. His abdomen is slightly distended, and he has some lower limb swelling up to his knee, which is pitting in nature. His capillary refill time is normal, and he is oriented to time, place, and person, and his extremities are also warm. Now, his creatinine is raised at 1.8, and his blood urea nitrogen is 30. However, his renal profile 7 days ago was more normal. Here's his chest x-ray. Let's pause for a minute. This x-ray is typical of pulmonary edema, with bilateral consolidations, interstitial edema, upper lobe cephalization, and also, if you look closely enough, you can see some curly B lines, which are these lines you can see at the edge of the chest x-ray, suggestive of interstitial edema. The impression from the history and examination is that this patient is volume overloaded, but has adequate organ perfusion. So we could say he fits into the warm and wet phenotype of heart failure. What's the management? Well, it's diuresis. It is not an impulsive fluid bolus to treat a number of poor kidney function, as this can often worsen the venous congestion from volume overload. The second case talks about a 55-year-old female who is brought to the emergency department for confusion and reduced urine output. This patient has a much lower blood pressure, and as you can see, there is also a reduced pulse pressure. We are also told that her skin is cool and clammy, and that she has an increased capillary refill time of 5 seconds, which is much longer than usual. Her creatinine is also increased, and so is the blood urea nitrogen. This is an image of her leg, and as we can see, there is a classic sign of mottling or livedo reticularis, which is suggestive of poor skin perfusion in the microcirculation. What do you think the management of this would be? This patient, we can call her clinically dry, so there's no need for extra volume offloading. This patient is in dire need of circulatory support, or support of her own circulatory system to perfuse her own organs. She needs close liaison with cardiology and critical care teams, and she would likely need higher care. What are some of the options for circulatory support? Well, we have chemicals such as inotropes. Now we have options such as dobutamine or milrinone. We also have various mechanical options. On top right, we have the intra-aortic balloon pump. In the bottom left, we have the impeller device. And we have various ventricular assist devices, such as the LVAD or the RVAD. And on the bottom right, we've got a picture of the LVAD. And of course, ventricular assist devices can be bridges to more definitive treatments, such as a heart transplant. We must remember that these phenotypes of congestive nephropathy versus a hypoperfusion causing kidney injury, and also the phenotypes of different categories of heart failure, can be mixed and confounding in nature. For this reason, we must use all the evidence we can, in the form of history, examination, imaging, to come up with the best management plan for our patient and his or her particular case. If you enjoyed this video, don't forget to subscribe and stay tuned for the next